I'm Magdalena Moshi, an Olympic swimmer from Dar es Salaam, Tanzania. I'm here with the Royal Australasian College of Surgeons. I've been working in HTA for 12 years, and I'm here to introduce Plenary 3, NextGen Participation. How can we use HTA to achieve more transparent, equitable, and fair health systems?
Welcome all. Cliff Goodman here from the United States. Along with my dear co-moderator Iga Lipska from Poland, we welcome you to the third plenary, which should have a different slide that gives us the title here. There it is, thank you. Plenary 3, NextGen Participation. Key word, participation. How can we use HTA to achieve more transparent, equitable, and fair health systems? Why this topic? You may recall in Plenary 1, we took a very careful look at new technologies and other developments coming our way and trying to understand how to embrace change. The second plenary dealt with, well, how do we do that? What are the methodologies we need to advance in order to cope and embrace that coming change? Here for the third plenary, we have to not forget that we need to ensure participation in all the above. We need to ensure participation. And that covers transparency, equity, diversity, fairness, trust. Now, as we've heard, I love artificial intelligence. It's great, but you also know, we know, that AI can perpetuate and propagate biases. You know that, not good. I love telehealth, and I heard a lot about telehealth. We know that telehealth can exacerbate disparities. It can widen disparities. So, and we also know, no matter how we do this stuff, we always leave some people behind, and some people are forgotten, and some people are ignored. So, i.e., the thread of this participation. And I might also add, at the risk of not being able to go home tonight, that we cannot forget the context in which we live. I am somewhat familiar with a country, for example, that is working to diminish transparency. It's pushing back against equity. It sometimes vilifies diversity. It is not advocating fairness, and it is undermining trust. That is the context in which many of our countries are operating, and don't be fooled. It gets to the work we do every day. So, now that I've given you a little bit of context, you know where we're headed. We have a wonderful panel here. To Iga's left is Karen Parras-Villanueva from the Philippine Alliance of Patient Organizations in the Philippines, followed by Emilia Caro, who is the Global Chair of Women in Global Health, Argentina, Adolfo Rubenstein from the Center for Implementation and Innovation in Health Policies, the Institute for Clinical Effectiveness in Health Policy, Argentina, and a special addition to our program is dear Virginie Giraud, who is the Director of HTA Strategy and Policy at MSD. She's based in Canada. The reason why I was so glad to have her here is that our original panelist who was going to represent industry, Stacy Kowal from Genentech, like many other people, couldn't get out of the US to get here because of travel delays, cancellations, and terrible thunderstorms. And at the last minute yesterday, we found her. And I already liked what she says and what she does. So, thank you so much. And with that, I want to hand the next comments over to my dear colleague, Iga. Iga.
Yeah, so thank you so much, Cliff, for this introduction. So as an opening question, we would like to ask you, just in a few words, 1, maximum 3, please indicate where is HTA falling short in aspects of transparency, equity, representation, diversity, or trust. So you've got QR code here, so we will give you 1 minute. So the question is, where is HTA falling short? What do you think? Just indicate 1 word, maximum 3 words from you. Oh, sorry. Sorry.
So Iga, this is like we're not doing so well, right?
Let's see.
with these words.
Let's see. So we think we are not doing so well with regards to transparency, diversity, equity, representation, or perhaps misrepresentation, or trust. The QR code is not working. Amran, can we open the poll? Amran? Now it should be okay. I've got the signal, now it should be okay.
Good.
So once again, just indicate in one question, in one word, maximum 3 words. We want a short phrase from you. What do you think? Where is HTA falling short right now with regards to transparency, equity, diversity, representation, or trust? Okay, so we've got such answers. As you can see, equity, trust, transparency, representation. Okay, rare disease, education and trust, that's important. Knowledge translation, that's also important. Oh, that's a wonderful word. It's unrealistic. Okay, let's talk about this. Trust with payment. Okay, tango, that's a brilliant word here. Okay. Not decision makers, industrial government, simplicity, reliability, predictability. Okay, representation, equity. Okay, so we've got at least good start for our discussion. Clive, the floor is yours.
Thank you. Perfect. And by the way, let's leave these up during our panelist commentary. I know that we have to turn off the Sligo to shut it, to make it static, but let's leave this up for a while if you don't mind. Okay, starting again from your left to right, and Karen's going to be up first, we have asked each of our panelists to hit the high points in no more than 6 minutes. Give us your best 6 minutes on this issue. And we've also said we need to be honest with ourselves. So we're not so interested in sugarcoating and la, 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 and isn't everything great. We need to be objective and look at ourselves in the mirror. Karen is going to give us her best first 6 minutes, and we'll go right down the road. You're up, Karen.
Thank you, Cliff and Iga. Good afternoon to everyone. I'm Karen Alparce Villanueva. I'm from the Philippines, which is an LMIC composed of 120 million population. So we have a devolved healthcare system, which results in a lot of fragmentation with respect to care. And 44% out-of-pocket expenses is spent by the average Filipino family. And so one catastrophic disease can drive a middle-class family into poverty. We passed the Universal Healthcare Law in 2019, and as part of the law is the establishment of HTA as a mechanism for priority setting. So HTA is institutionalized, including the participation of a citizen representative as part of the Health Technology Council. So we have a growing patient movement in the Philippines. So under my alliance, there are 54 disease-specific groups. We like to see ourselves as a sanctuary for loosely organized and not legally organized patient groups who either lack the capacity or the voice or platform to propose their advocacies. I've been working with PAPO for the past 10 years, and because we show up for all the meetings, the consultations, we raise our hands, we knock on doors. We are now part of a lot of technical working groups, councils, and coalitions that help shape policy. PAPO is focused on patient rights, patient participation in health policy making, and universal health coverage. So the question is HTA fulfilling its mandate? And I base my answers on a recent study that we had together with Costello Medical Consulting UK, where they took a look at 10 countries, looking at patient involvement in HTA. And these are the findings. And I'd like to share from the lens of a patient these aspects in terms of the findings. So for transparency, there is obviously a lack of trust and communication between the HTA bodies and the patient groups. Even as we sit as part of the citizen representative, that's just one person, correct? And there are so many processes involved. We also are not made aware of the outcome of the decisions with respect to HTA, so resulting in a lot of anger and a lot of suspicion, etc. And there's also a perception that patient orgs are influenced by the industry, so they're a bit concerned and think that we are biased. So in terms of equity and diversity, so the Philippines is an archipelago. So you can just imagine that in terms of reaching indigenous people and those who live in geographically isolated and disadvantaged area, couple that with issues on Wi-Fi connectivity, yes, something as basic as that, then you can imagine that most of the representation are really in the urban centers or in the cities. Okay, in terms of trust, again, there's a lack of trust and familiarity between HTA bodies and the patient groups. Again, as mentioned also, patients lack the knowledge about the HTA process. We also lack the capacity to be able to generate evidence. But this capacity is also an issue with respect to our HTA agency. There's very little appreciation for HTA at the legislative body in our Congress. So they ask for things that are politically acceptable or politically attractive, not knowing that there is a process and there's a timeline to be able to do that. And exactly why there's HTA in place is to take away a lot of the political pressure. But it continues to happen, and that's the reality. So in terms of fairness, also, aside from patients struggling with the process, we also struggle with simple language, like we don't understand medical jargon and etc. And there are also issues about patients who are willing to participate in the process. So many patients are concerned about access to treatment, which is very basic. And so, therefore, it's quite difficult to be able to find volunteers to be able to participate in this process. So from there, Cliff, that's my view from the patient involvement part.
Thank you, Karen. You were giving us the right idea, and I would say we're not doing so well on our report card, are we? She went right down the courses, you know? Thank you. Amelia, Chair of Women in Global Health, what do you have for us?
Well, I think, Cliff, that you frame my participation pretty clear. In these days, having women and global health in the business card is not the most trendy topic. So, to boost my popularity, I've been asked to speak about equity. Thank you. Well, let's start for what I think, about this. And I will frame my intervention. My intervention is not technical. I don't come from HTA. I come from global health. I work with frontline workers. I work with fragmented healthcare systems here in the Global South. So this is my intervention where and I will share what I've seen during these last days that I've been very involved in this conference with learning from all of you from HTA and what I think I can add from the equity perspective. I want to talk about HTA, not just a method, but maybe as a mirror, who we center on the frame and who we left out of the picture too. I think this tells a bigger story than just a method. But to talk about equity, we must start about being precise, I've learned, mainly during these last days, that equity is not a fixed definition. It depends on where we stand. And what's equity for whom, So maybe for Global North, equity is about age, it's about insurance status, it's about even it's about disabilities. But for Global South, where I live and work, equity, it's about structural inequalities. It's about the burden of caregivers. It's about not just gender, age, the rural and urban divide. It's about even the digital deserts we have here. So it's very important to know what we are talking about when we are talking about equity. So whose equity are we talking about, you know? Because if we don't, we risk building first systems for some and invisibility for others. But in my experience, and let me offer a different perspective from the moral aspiration of equity. Equity is not charity, but it's smart politics. And that is, don't feel sorry for me that I work in this field, but I've learned that it's not about charity, it's really about smart politics. It's how we prevent innovation from becoming a stranded investment. It's how we build trust too. So, and even how we prepare systems not to collapse when they come under pressure, you know? So I think that we all need to work together to make leaders understand, and decision makers understand that equity is design and it's smart. I think that HTA has an immense power, because you define what is visible, you know? You define what is valuable. But the thing here is that maybe we need to work together and to cross these different silos that we work in is valuable for whom? You know, it's accessible to whom? And prioritized by whom too? Those are the questions that we need to address. Because a technically flawless valuation can still be profoundly unjust. If we ignore who lives behind, I think that we all know that health technologies don't land in our clean graphs. You know, they land in, at least from my experience, in very messy realities. So those realities are always shaped by gender, age, by diversity, by income, by power. So we need to know very clearly which voices we are hearing whenever we speak about equity. And so the question here is, what do we do, you know? what do we do with all this? And I'm molecular biologist and data scientist, and I think that what we need is to measure. I mean, equity is not just to declare, we need to measure. So maybe you will know the answer, but what I've found during these days is that maybe we need access metrics before and after HTA. Maybe we need to disaggregate the impact by age, by gender, by location, and beyond, maybe even not just that. So we can measure the equity or not in HTA. But mainly because, and this I'm saying, I'm stating this as a data scientist, if we don't measure who benefits and who doesn't, we are not practicing evidence-based policymaking. We are practicing selective blindness. And this is very important for us to have in mind whenever we are evaluating. And let me say something that it really touches me. When I hear about well-intentioned health tools that speaks only to mothers, not caregivers, but to mothers, it reminds me how easily bias becomes designed. Bias isn't always loud. Sometimes it's just a legacy. That's why HTA must go beyond evaluating evidence. it must interrogate the assumptions behind the data sets, behind the evidence there. Because when systems are designed by same kind of people, for the same kind of people, always others are left behind. So these assumptions don't just shape the outcomes, they shape the entire system. And I just want to close with some experience I have from the global health, and it's very important to bring the Global South to the center of the conversation, because there is where most equity is needed. But not as a beneficiary, not as an implementation site, but as a space of knowledge, of innovation, of leadership, because fairness doesn't just mean improving access. It means redistributing power over what counts, who counts, and what we choose. So the answer was how we make HTA a driver of transparency, equity, and fairness. Is that what we've been asked here? Well, equity is not just about affordability, it's about representation. Fairness is not just about who gets in, but who shapes the system itself. So we all in this room have a responsibility, and I invite you all to show with evidence and to demonstrate that equity in HTA is not charity, but smart politics, because it protects trust, it prevents backlash, it builds systems that don't collapse because they were built for everyone, and let HTA become not just a gatekeeper, but a force or a guardian of justice, un guardián de la justicia. Gracias.
Very well stated. Thank you. That was nearly poetry. Thank you, Emilia. Now, Adolfo has had rather prominent positions in Argentina, and he has a key role in one of the global best-known HTA organizations. Adolfo, what do you have for us?
Thanks, Cliff, and good morning to everyone. Let me introduce briefly myself. I'm a physician and epidemiologist.
Right into the microphone.
I'm sorry. I'm a physician and epidemiologist and researcher, and one of the founders of IEX, our institution. And because of this strange alignment of planets, I ended up being Minister of Health in my country from 2017 to 2019, because I'm not coming from politics, but I learned a lot. And throughout my career, so I've had the opportunity to move from the research side as an investigator, even in the HTA world, and as a practitioner also, to the policy side as a Minister of Health in my country. And having been at both sides of the aisle or the table, as you say, or ambos lados del mostrador, as we say here, allow me to understand the different perspectives of those who generate the evidence or translate it to the real world, to those whose job is to decide on the adoption and implementation of health policies. A very different perspective. And what I learned, that HTA researchers, as most clinical researchers or implementation researchers, and policymakers live in different worlds with different environments that often lead to communication challenges. They have different languages, culture, norms, jargon, codes, and that's why engaging policymakers is not just about presenting data or research evidence, but it's also about presenting a compelling narrative and a value framework aligned with policymakers, which is different from the value framework of HTA researchers. So value framework of policymakers, and I learned that in my post, is mostly driven by politics, not by evidence or not by science. And that's a different thing, and I think that we have to understand to communicate with policymakers. You are probably familiar with the WHO blue cube, right? Which is inside a bigger cube. As you know, the blue cube represents the current pool funds. And to pool the necessary funds to get to the universal health coverage, which is an aspirational goal even in high-income countries, you have to advance in 3 dimensions. To expand health coverage to the whole population in the horizontal axis, to increase the quantity of service covered in the diagonal axis, and to provide financial protection by reducing out-of-pocket expenditure in the vertical axis. But the cube does not tell us the whole story. Unless you have unlimited resources, and we know that that's impossible, and if it could happen, we wouldn't need economists at all. You cannot advance in the 3 dimensions at the same time. So the question is, what to expand next? What to do next? To cover more people, more services, not to leave anyone behind, or less financial, or to provide less financial hardship at the point of utilization of health services. And oftentimes, the policymaker has to make very difficult decisions because they have to balance the trade-offs between innovation on the one side and equity, efficiency, and sustainability of health systems on the other side of the scale. And what is the place of equity and fairness in this equation? Because you know that, and it's quite common nowadays, with the increasing emergency of high-priced drugs, for instance, innovative drugs in the pipeline, which they are very promising, but with marginal cost effectiveness and a high budget impact. And in the same line, how to address the dilemma posed by some rare diseases that have effective treatments, but compromise at a compromise of health budgets in the short term. And let me tell you a story of a very difficult decision I had to make when I was Minister of Health. At that time, 6 years ago, the coverage of Spinraza, nusinersen, was in the rise. And this is a treatment for spinal muscular atrophy, a rare genetic disorder that affects infants at infancy and early childhood. That may cause in some subtypes fatal disease in less than 1 or 2 years. And at that time, for the first time, that disease carried with a effective treatment that prolongs life and improves quality of life. And of course, treatment was claimed by the families of approximately 400 children that we have registered in Argentina. The whole budget to cover the market price set by the company at that time, which was $700,000 the first year and $300,000 thereafter, amount a budget of $300 million in Argentina if we could treat all the children affected. And that would mean, and that was similar to the cost of the whole national immunization program, composed of 20 different vaccines for different schemes in more than 15 million children and adults of risk. So what to do? even though we finally negotiated with the company a huge reduction of the price, of course the decision was not cost effective in terms of budget allocation. But we did it for equity reasons, in order not to leave anyone behind, fairness. But the story shows, perhaps dramatically, what an opportunity cost means when you have a limited budget. And finally, let me tell you something that we should not overlook when we are incorporating a new technology into a benefit package, such as the PMO in Argentina, which is our basket. There is always a trade-off, an efficiency equity trade-off, since new technologies are usually more cost-effective in the wealthy and those who have access compared to those who have not access or are uninsured, the poor. And new technologies can paradoxically, in the outset, increase the health disparities. So this is something that you have to take it in mind. In the end, and to conclude, 6 minutes? The great challenge of HTA is how to bridge the gap between innovation, efficiency, and equity, but in a transparent, objective, and explicit way. To serve the public good, but not to leave anyone behind. And most importantly, try to sustain health systems in the long term. Thank you.
Thank you very much, Adolfo. You know, it's good to hear from you on this because you have had to face the research side and the policy side and weigh those in light of trying to achieve equity and fairness. Not so easy. You demonstrated that very, very well. Now let us go to someone representing truly one of the more innovative corporations around the globe, MSD, and it is very important to hear the industry perspective. Virginie, you're up.
Thank you. And I'm going to be a bit different because I grow restless if I sit. So first of all, although I am an employee of MSD, I have to say that I'm representing my own person and the views I'm expressing today are my own and not necessarily those of my company. I'm very happy, I'm honored, and quite frankly, a little bit surprised to be here today, but hopefully I can do justice from the company perspective. So I'm going to talk about trust, and I'm going to link trust to a couple of different things. The first concept I want to link trust to is patient engagement. And the reason I say that is that I do sincerely believe that it's much easier to trust a process, a recommendation, a decision, if you actually have been involved, if you feel like your voice was heard, if you feel like you've had a say in it. And this is, unfortunately, where I find that sometimes globally, HTA falls a little bit short in terms of having meaningful patient engagement. Now, if any of you have ever played Uno, the card game before, you know there's that little reverse card. So I will play the reverse card, I will look in the mirror and say, I think traditionally this is also a place where industry has fallen short. Now, not in terms of engaging patients through the HTA process, because I think that we've gotten pretty good at. It's more about considering the patient voice really early on. When we design clinical trials, if we had the discussions with patients, what are the prems, what are the proms, what really matters to them, we could try to incorporate those in clinical trials and generate the kind of evidence that HTA can then discuss with patients. So I do think that this would support better engagement at the HTA level as well. Now I'm going to open a can of worms. Okay? So I know it's not topic, but I think it's important to pose it here. When we talk about involving patients earlier on, when we talk about trying to measure what really matters to them, well, it poses the question of, well, what if what they really value is not a traditional clinical endpoint? What if, for example, in a therapeutic area, what they value is being able to be autonomous and independent in their day-to-day task and returning to that level of autonomy. If we as data producers in clinical trials were able to qualify, quantify, measure that, and give it to the HTA, what do they do with that? And so I think this opens the question of how do we incorporate broader elements of value into how we do HTA? Closing the can of worms. All that to say, I do think there is light at the end of the tunnel, though. This is not all bad. There are good examples. We'll get into success stories later, but I think both sides are getting better at patient engagements. The other thing I want to link trust to is transparency, because here again, I do believe that it's much easier to trust in a process, a recommendation, a decision, if you can understand it. But to understand it, you need to have the information to allow you to understand it. And again, I think this is where sometimes HTA falls short. HTA can be this black box of, okay, manufacturer, here's my data, put it in the box, then the box does what the box does, and spits out a yay or a nay or maybe an ICER, and that's it. You cannot understand the no. Why did it say no? What happened in the black box? So if we have a sense of not only what is valued, what kind of evidence do HTA want to see, but also how do they evaluate what we're submitting, then it's much better for us to go back to the drawing board and try to incorporate those considerations and those methodologies into how we do clinical trials. And then I do think this will just facilitate the whole process and make everything a little bit easier on everyone. Now, let's say we do that. Let's say HTA tells us, this is what we want to see, this is how we're going to look at it, and let's say we do it. But somehow, you know, HTA is a deliberative process. There are different values at play. Let's say the answer is no. Okay. Help me understand. What was the no for? Where did it come from? What elements were unanimous? What domains of value were contentious? So that I can then go back to the drawing board and look at my value evidence plan and try and resubmit again and do address the uncertainties that were raised. Here again, I do think we're getting better. So there is success, light at the end of the tunnel, but I do think that globally we fall short here. And with that, I will yield the floor.
Thank you, Virginie. You know, we didn't put it in the program, but we missed the whole thing on autonomy, and you just brought it up. And if that's a can of worms, don't close it, leave it open. Over to you, Iga.
Yeah, thank you so much for your presentations or brief statements, actually. So we've already diagnosed the system, so we know we are falling short with regards to transparency, representation, equity, and trust. So have you got any recommendations? What can we do to fix it? Have you got any examples of success stories? Perhaps we can start from Karen.
Okay, so I listened in on the patient and citizen involvement group, and I learned that there are some best practices out there, particularly by the UK, NICE, where there is a standard procedure for providing detailed feedback to patient groups. So it was already mentioned that the problem is we submit and then we just get a yes or no. We're allowed to appeal to the process, but we really don't understand where we failed or where we had gaps in our submission, even as we were already trained to be able to submit this. And then also, maybe it might be helpful if you can acknowledge patients and caregivers as experts, including a summary of our input in the final HTA recommendations. So it's merely giving due credit to the work that the patient groups have given and the caregivers, because it does take work on our part. As you all know, most patient groups, and especially in the Philippines, we work pro bono. We don't have very organized secretariats. We're very loosely organized, and that's the reality. And many of the patient groups actually are those which do not have policies in place. So you can imagine how much of a startup these patient groups are, and many have to spend for transportation just to be able to participate in these processes. And then also regularly disseminate a calendar of upcoming public consultations through websites, email lists, and partner social media. So don't make it a one-off announcement via your social media, but try to reach out to many more patient groups so that many more patient groups are aware of these consultations. And of course, ensure that the roles and responsibilities of patient organizations are effectively communicated to patients by developing a formal guidance document. So what we have in the Philippines is a code of ethics in dealing with the industry and with the medical societies, but nothing in terms of dealing with government and especially with the HTA bodies. In terms of equity and diversity, for certain appraisals, engage multiple patient groups to provide diverse perspectives and encourage each patient group to select a wide range of representatives, so not merely those coming from the urban areas, but especially those who come from marginalized communities. And of course, use a variety of dissemination methods, including online platforms and social media to reach a broader patient base. And of course, as mentioned already earlier, develop lay-friendly glossaries and patient-friendly simple language summaries at the start of the HTA process. Develop training sessions and materials, and preferably infographics. Upskill patients and allow us to fully engage with the HTA process. And also cite excerpts or good submissions so that we learn from this. And of course, finally, in terms of building trust, create comprehensive process guidelines and host patient workshops to outline the roles, responsibilities, and expectations. So also codifying how we deal with each other would also help. Provide training on patient engagement principles and practices, also for HTA bodies. So, helping each other understand what we're all trying to do, maybe having more conversations with them. And finally, if it's possible, establish a standing committee or advisory group for patient involvement. So this is like a way to be able to improve or enhance patient involvement by having an external or advisory committee that continually looks at the process. I think patient involvement is nothing static, so we could be moving one step forward, but finding ourselves, 2 steps backward. So it's good to have a periodic review of how we're doing. And of course, participating in conferences like this where we learn from the best practices of the other countries. So thank you.
Thank you so much for your intervention. Karen, what do you think? Have you got any success? Emilia, what do you think? Have you got any success stories to share with us with regards perhaps to gender diversity or other stories to share?
Maybe just a reflection. To hear me okay? I think that I would include to what just Karen said, to involve, that HTA should involve epistemic diversity, not just to value experience and lived knowledge, but something that I think it could be very important is that these standards should be applied like in both directions. If you have a product or a technology that was just tested in just urban white male, and it's supposed to serve to a wider population, HTA should call out that, so it should be important. So it's just not in the process to include the equity, but how we evaluate those technologies should be very important too.
Thank you so much. Adolfo, you've got this unique perspective of decision maker and researcher. So have you got any recommendations how we should fix the system with regards to all these values mentioned: transparency, trust, representation,
Thanks.
equity, of course.
You put me in a very difficult position. I'm no longer a policymaker, but I was thinking that maybe, and that's my opinion, in our culture, I mean Latin culture, transparency is a difficult issue. Because of our probably paternalistic culture, and it's a difficult step to involve all the relevant stakeholders to be seated in the same table and to consider all the perspectives, for instance, patient groups, but not the public just, I mean, on the one hand, the patient groups, on the other hand, the taxpayers or the public at large, who usually have, I mean, another perspective of how to disperse the money, for instance, and who should make the decisions. I mean, should the industry be involved in the decision making, or like patient groups should be heard? And because, I mean, everyone has a say, but the question is who should make the final decision? And I think that in order to improve transparency, and because in Argentina, as in other Latin American countries, it's very common to judicialize, you understand what I'm trying to I mean, how do you say? Judicial, I mean, to litigate or
Legislate.
Huh?
Legislate.
No, it's not legislation. It's the judicially. Yeah,
Yes.
suing people. Suing people. and why is that? Because on the one hand, maybe some countries do not have a body, an HTA body. Now in Argentina, this is starting. I mean, when I was minister, we initiate this process, but unfortunately, we couldn't make it. But well, it's a process. Now it's getting real. But it's not just to create a HTA body, it's how to legitimate that body.
Legitimize.
And that's very different. So I would say, on the one hand, to create a legitimate body, but not that the structure or on the surface, but also to really develop a stakeholder mapping and a political analysis to know with some precision the vested interest of each of the stakeholders, the influence, the power, the position, the intensity of the position, and try to sit everyone in the table in order to listen each perspective and finally to make a decision, but fed by all these, different points of view.
Yeah, but can I ask you a more detailed question? Sometimes patients, insist on a timely decision making, and when you want to involve everyone, it takes a lot of time. So have you got any recommendation and a solution to that?
Well, it's for me or for?
Yeah, it's for you.
For me. Oh, I'm sorry.
Sorry.
Well, first you have to create the environment to do this. Of course, to accelerate the decision making. I understand some decisions have to be made, rapidly. And you have to get the process ready. The process.
Okay, thank you so much. And Virginia, if you could share your industry perspective, perhaps you've got success stories to share.
Yes, and I apologize, my frame of reference is very Canadian. And now, as I'm saying this, that was very Canadian of me to apologize for that. But my examples will be mostly from Canada. I think in Canada, the CDA and UNES, our HTA agencies, have done a lot of work towards improving patient engagement. You probably have heard Nicole on some stage here talk about it, but it's true, it's not just lip service. they looked into the processes and they go above and beyond just the simple, okay, here's the stakeholder input form, fill it out and let us know what you think. There's actually now some review processes that allow for patients with lived experience or caretaker with lived experience to be at the table when they deliberate. They also have a patient representative on their board of directors now. So it's like the commitment to thinking about patient engagement, not just from a review perspective, but as holistically as an agency, I think is quite obvious to us in Canada. And so, you know, shout out to them for that. I think they also do a really good job with transparency. They've improved quite a lot. For years in Canada, industry asked, what's in the black box? Please tell me. And they finally did it. They have this methods guide that they released not too long ago where they tell us, here are the types of evidence that we look at, here's how we appraise and value different types of evidence. And then they added one step further and they said, and this is how we deliberate. So they actually told us, our committees look at all of these domains of value in their discussion. This has been fantastic for us because I can take this back to my global organization and say, hey, you know, this is important in Canada, and perhaps we can consider some of those things in there. And then one last example tied to my can of worms. So I'm opening it again. I do think that, I don't know if some of you have heard of the HEMA collaboration, but it's a collaboration between ICER in the US, NICE in the UK, and CDA in Canada, where they're actually trying to tackle, okay, well, how do we consider those weird elements of value into health economic modeling, for example, value of hope, how do we consider that? So we're not there, because this is a very heavy topic and it's not easy to do, but I think we're asking the right question, and you can tell that there is at least the willingness to kind of evolve in that direction. So like I said, there is light at the end of the tunnel, so.
Okay, thank you. The reason we asked our panelists to get to the point in a certain amount of time is to protect your time for Q&A. There are 2 aisle mics there, and if you have something to say, again, looking in the mirror critically, that's fine. So you can say what still needs to be fixed and or how would you fix it. So I'm gonna look for people to come to those mics now. And by the way, if you know me, I may call on you if you don't come to the mic. So when you do and have a question or point to make, it can cover any of transparency, equity, fairness, diversity and inclusion, and autonomy, and even cultural values. So those are all fair game. Give us, maybe not a long speech. We're not here for speeches, but if you've got a good pointed question, we'll take it. So I want to see a brave person. Come to a mic. Where's a brave person? Robin Manuel, are you there? Okay, all right, Robin, you're second in line. I saw you start to get up. Is that Alexander?
Yes.
Give us a good question, Alex.
Okay, it would be in the transparency. And the very good point made by the representative from the industry, which is, sorry.
Virginia.
Virginia, thanks. It's very good comments. So you mentioned about the importance of the transparency, and I totally agree. I think we should have more transparency. I would like you, if you could comment on what contribution the industry can give to increase transparency. So I just mentioned the recently royal decree from Spain on HTA, another one in pricing, and they established the need for transparency for research and development costs. If you think this could be a good way to go.
So I'm not familiar enough with this initiative to comment specifically on that, but I do think that we have our role to play in transparency in industry as well. If you look back in, again, in Canada, sorry about that, 5 to 6 years ago, it was not uncommon to see HTA recommendations that were fully redacted because the manufacturers were like, oh, that's confidential, oh, that's confidential, oh, that's proprietary. And so how do you want people to understand what's behind the decision if all you have is a black sheet? I think, again, you know, the CDA and ENS have kind of clarified the rules in terms of what they deem redactable, and, you know, industry complied, and I think it's for the better. I think it improved a lot with regards to that. So it does go both ways. But sorry, I can't comment on your specific, maybe someone else is familiar with it and can go ahead and.
Thank you, Alexander, very good. Who's coming up next? Robin, I think you were second. Robin, I know you're active in this field, what you have, and then we'll go to the third question. Thank you. Robin.
Hola. Thank you so much for your contributions this morning. So I have to try not to speak my language. I'm from Aotearoa, New Zealand, and I'm Indigenous. So I think I might just look at your question and reframe it. Can we use HTA as it currently is to achieve more transparent, equitable, and fair health systems? I believe, no, you can't. Not yet. Your framework needs some help, and it needs to be diversified. Are you able, is the HTA community able to embrace Indigenous wisdom? Are you able to welcome Indigenous people with our Indigenous knowledge, our Indigenous ways of doing into your space? Can you credit our knowledge with the rigor that you seek? And when you can, then we can enter this space and bring our entire authentic Indigenous selves into the space of HTA. That is my question to our entire community, because when you can embrace us in our full authentic Indigenous selves, then perhaps we can collaborate, perhaps we can achieve more transparent, equitable, and fair health systems. I also want to thank you, Amelia. You said something, and I'm just going to read it on my computer. You said that HTAi has huge power, and you do. HTAi has huge power. If HTAi can embrace us, then our own HTA in our respective countries will respect our perspectives more. Just a comment. Kia ora.
It was an important comment. Thank you, Robin. Okay, who's got Indigenous ready to go? We need a response. Go ahead.
It's a very challenging topic. Kia ora, by the way. We have a big Indigenous population in Canada as well, very diverse, because the territories is big. And I don't think we've figured it out from all the perspectives, even industry, right? Reaching out to Indigenous population to get their voice heard, we're not doing a good job. So I agree with you. I do think that it's important, and it's promising, at least in Canada, that our governments are committed to reconciliation and trying to find ways to have meaningful engagement and embracing. I love how you're saying that, but I don't have a solution. We're still, if you have ideas, please. I think we're all ears, but it's a very good point.
Thank you. Any further comment with regard to Indigenous inclusion? Yes? Okay. Thank you very much, Robin. You've given a charge not only to this panel, but everyone in the room and to our organization. We're not going to forget your charge. I don't know how well we're going to do, but we've got some work to do. We're going to the back for the next question, and I do know that my Canadian medical device colleague also had his hand up before, but
I have a mic here.
you've got it. Take it.
Okay. Thank you, everybody. My name is Flor Braga. I'm from Argentina, from the Alliance of Patients with Rare Diseases. And I ask everybody in the community if you can help me with the answer. Because what we are feeling, I'm not speaking about myself, all the group of diseases in which we work, what we are thinking is that the access to human rights, health as human right, and when I speak about right, it's the right of access to precision medicine, the good medicine, the good technologies, the best technologies that humanity can offer. We are talking about something that is very subtle, but it's gonna change. So we are speaking always about health as vaccines, good food, sport, but the idea of precision medicine is far away now from the idea of human rights. And my question is, do you really think that HTA helps in any way to the access? Because we don't think that. We think that it's impossible to be as transparent as we need and as intelligent and creative as we need. And we think that really the researchers are our best associates in the in the lack of cure, trying to find cures. But this situation is so long and so absurd in many terms that I want to ask your help.
Thank you very much. I'm going to pick on you, Adolfo. Precision medicine for everyone. How do we ensure that we address the very fine and thoughtful question? Precision medicine and transparency, equity, diversity, etc. Have a good time with that one, Adolfo.
Difficult question.
Close to the microphone. I know you're going to say something
sorry.
great.
I think that we cannot overlook precision medicines as all the disruptive treatments that have appeared in the pipeline in the last 2 decades. So, and we cannot overlook that. And I think that it's a question of fairness and equity and transparency to include this in our repertoire. And I think that HTA has a lot to do with that. Again, it depends on the perspective. If your perspective is the perspective of the society as a whole, the public at large, the taxpayers, well, maybe you have another perspective of how to allocate your, limited budget. But they are very difficult decisions. Let me tell you an anecdote okay. A short anecdote. But reflects, the challenges of someone who is in that position as a policymaker. I remember when I was minister in 2018, I went to a TV program with a lady, but lady is not a lady. It's Mirta Legrand. Probably you know. It's an old woman who is revered like a hero of TV. She's now 27, 28 years old, but she's great, and she's a hero. She's a hero. And I went there, and at the when I entered to the studio, before entering to the studio, when I entered to the studio, a group of patients, families with children with SMA, stopped me and request to cover Spinraza. And I remember that in the program, Mirta Legrand said, why you are not covering Spinraza for these children, poor children? So, and I tried to explain in a more plain language what I tried to explain in my speech, early on. And it's very difficult. It's very difficult. Are dilemmas that are very difficult to solve.
Thank you very much. I'll just throw in quickly. Personalized medicine is in part about the molecular biology and finding the genes and all that. But for everyone, it is also about what we call the exposome. All the risk factors in the environment, which could be water pollution, air pollution, noise pollution, being worn down by discrimination every day, that is part of what can make better personalized health care if we are able to gather those data. Thank you so much for your question. I think, Luisa, you're next, huh?
Hi everyone, my name is Luisa from Switzerland. I think I might go back in the discussion a bit and build on the topic Robin was making before. In the discussion, we were focusing a lot on making HTA more equitable, more transparent, and more fair. But I think there is an opportunity of discussing how can we keep HTA as it is and help it and use it to help to make health systems more transparent and more fair. And I think about, for example, priority setting in healthcare in general. Can we use our evidence-based approach to highlight access hurdles for the medicines that are already reimbursed? So I think there is an opportunity to explore beyond the pure HTA. But if we keep everything as it is, how can we try to make those messages that you just made more easy and make these inform like other healthcare decisions and make the systems more fair for everyone?
Are you asking how do we step out of the traditional scope of HTA? Is that what you're asking?
No, even if we keep HTA as it is, how can we use the information and the resources and the tools we have to help the health systems? And we have previous Minister of Health in the stage. So is there an opportunity to make this more just about the assessment of one technology, but applied in the whole system?
Thank you, Lisa. And I do think Adolfo hit on some of that, but I want to go to Virginia.
So in my country, we focus HTA on drugs and a little bit of devices. We're a tiny little portion of a total health budget. Yet there's no HTA that's being done on medical services, on how hospitals are run, what's prioritized there, and the budgets are still very much in silos. Until we break that, it's gonna be very hard because the choice is gonna remain technology A versus technology B. But maybe it could be technology A versus this model of care in the hospital. That would free up some budgets potentially, and then maybe we could have different priorities for drugs and devices and vaccines.
Very well stated, especially coming from the industry innovative side. Thank you. Question?
Hi, I'm Keith. I've heard a lot of talk about diversity.
Speak up, please, Keith.
I've heard a lot of talk from the panel about diversity and the value in reflecting, local countries' cultures and contexts. And Cliff, you touched on personalized medicine. Virginie brought up a personal passion of mine, which is harmonization, right? So, and I think that's why we're all here, is like, how can we take the learnings from each country and apply it to each, right? My question is, are those two things in conflict?
Which two things? Same again.
Diversity and local knowledge on the one hand, and then harmonizing decision-making and practice across those countries. Are those in conflict?
Diversity and harmonization, aligned or not aligned? Virginia, you...
I would love to...
Start.
Please, no, please go ahead. Please.
Well, I think that should be harmonized because although diversity and equity means different things in different areas or different sectors when we speak of, at the end it's the same. So if you harmonize that with the best standard possible to not leave anyone behind, it's a good decision for everyone. Whenever you are better in the ticking the boxes for equity or diversity, and whenever you are worse.
Thank you very much. Virginia, do you have something?
It's exactly what I was going to say, but she said it better.
What about personalized medicine then? So what about, you Cliff, you mentioned personalized medicine. Are those two things in conflict? Can they be brought into, confluence together? Any comment?
If you look broadly across risk factors and other aspects in all the omics and so forth, the exposome, there's no reason why this cannot be harmonized. One thing that helps us harmonize it, and this is good about things like AI and huge databases and powerful computing, is that we can in fact probe all those sources, even eventually on behalf of the individual. So in that way, I'm optimistic, but it could go wrong. There's a great way to use this, but there's not a great way to use this as well. Thank you for the question. Back to my colleague, Iga.
Yeah, thank you so much, and thank you to our panelists for discussion. So we've got one closing question for you. Again, you've got QR code, so please join the conversation. And the question is, what are the key fixers or gap closers to improve transparency, equity, trust? What can we do better? So I will give you 1 minute.
During that minute, please be doing this. Take these messages home with you. Please don't let them stay in this room. We have work to do.
Oh, that's interesting. Inclusion, support, honesty, embrace innovation. Oh, glass half full, okay. Cooperation, more collaboration, clear methodology, inclusion, support, connection, and listening to patients. More answers to come. Thank you. Cliff, over to you.
All right, thank you. All right, we can leave these up for a bit until we go to our transition. Thank you very much, Armin. There are many exciting things in our field, as we said before, all the great technology and all the cool things happening in all the omics and molecular biology and hyper-powerful computing and so forth. It's going to be too easy to forget the lessons that you heard today. It's going to be too easy to be starstruck by all the cool stuff out there. We have, in fits and starts, brought in patient engagement. And by the way, HTAi has done a good job of that compared to other groups. But it's too easy to leave all of this behind. So if you heard not only the messages from our wonderful 4 panelists, and you listen carefully to the kernel, the gem of every one of the questions that was just posed, you have the ingredients to remind you when you look in the mirror, the HTA mirror, to incorporate these and synthesize them and design them into how we advance the field here on. If you cared about these issues, about transparency, fairness, equity, and so forth, I hope you agree that you could not have done better than having panelists such as ours. Karen, Emilia, Adolfo, Virginia, you did a great job. Thank you so much. And we're going to take now to the next step. Don't forget these messages. Thank you all. Let's move on. Thank you, everybody.